Hello, and welcome to The Mind of a Therapist, a podcast where I interview psychotherapists and helping professionals and what they're passionate about in order to provide you with messages of encouragement and hope. I'm your host, Andrew Earl. The Mind of a Therapist is sponsored by Psychological Counseling Services, healing hearts and transforming lives. Look into our intensive at pcsearl.com. In today's interview, I interviewed Dr. Shulte. In 1970, Dr. Shulte graduated from the University of Michigan Medical School and attended the University of Michigan Psychiatry Residency training program shortly after. Dr. Shulte has a wealth of experience, having practiced and taught both psychiatry and psychotherapy throughout his 50-year career in Michigan and where he currently practices in Scottsdale, Arizona. So without further ado, here's my interview with Dr. Shulte. Dr. Shulte, thanks for being on the podcast today. To get started, your practice is a little unique. You practice both psychiatry and psychotherapy. I don't think I've met anyone who's practiced both, and I'd be curious in starting here. Did you start as a psychiatrist and then start practicing psychotherapy, or what did that progression look like for you?
Right. Well, when I trained in the early 70s, psychiatrists were taught to do psychotherapy back then, mostly psychoanalytic psychotherapy. And during my residency, I also got trained in transactional analysis and Gestalt therapy, and I did group therapy. So all the way along, I've been doing psychotherapy as well as medication treatment. Many psychiatrists only get reimbursed for medication treatment, so they don't do the psychotherapy component. But the last 10 years or so, I did group therapy all the way along. In the last 10 years or so, I've been private pay, so I'm able to do more psychotherapy.
Absolutely. And this interplay between psychotherapy and medication, I'm in a marriage and family therapy program right now, so I'm more familiar with the psychotherapy end in terms of treatment, not as familiar with psychiatry. So will you talk a little bit about this interplay between medications and psychotherapy, maybe when to use one, when to use the other, how they work together?
Right. Well, I'm a strong proponent of psychotherapy because pills don't teach skills. And psychotherapy is a valuable component to learn about our psychological makeup and how to manage our emotions and our relationships and our life. And so that's very important. So if we look at the psychiatry component, more the medical model, reminds me of the story of the Hindu Indian story from many years ago. So they took these three men into a room and they blindfolded them. And they said, "We're going to take you outside and we want you to describe what you feel." So they took him outside, and an elephant was there, and one felt the ear and said, "Oh, this animal is a fan-like animal." Another felt the leg and said, "No, this thing is amazing. It's like a column that's so big and strong." And the other one felt the trunk and said, "No, it's serpentine." So the way we look at problems determines somewhat what we do about it, but it's also important to look at problems from many different angles. So as far back as the ancient Greeks, 300 BC, they looked at melancholia. Simultaneously, they identified melancholia, people who were depressed. They thought their bile was involved in it because they saw a lot of physical symptoms with it. Simultaneously, Aristotle was defining the beginning of Western science. So he was saying, well, these trees are in this phylum, in this genre. Some lose their leaves, some don't. So in the history of Western science, we look at collecting data and coalescing it into units, and then looking at what we do with that unit, that collection of data, and advancing our knowledge that way. So in medicine, we've done that with looking at symptoms. So we are now on our 5th edition of psychiatric diagnoses, so it's a process for sure. I think the first one came out in late 60s, early 70s. So let's take major depression. So when someone says I'm depressed, that is a normal feeling. It is not a diagnosis.
Mm-hmm.
It may be an inclination. It may be they're sad about something that happened in their life, a loss, or it could progress to become an illness. To become an illness, it has to meet these criteria of usually depressed mood, and that's almost always there. But certainly, in addition to that, lack of motivation. So they're more socially isolated. Hard to tell that apart today from COVID, of course, because COVID is a big factor now in depression. Decreased appetite, difficult to sleep, trouble with thinking, concentration, decisions, decreased motivation, and sometimes suicidal thoughts. So when we have that cluster of symptoms, and it's every day for 2 weeks, and it interferes with somebody's life, that's a crucial piece of this.
Mm-hmm.
That is a medical diagnosis of a shift in the biochemistry of the brain. It's not a personal failure or moral weakness. But people, when they get depressed, feel like they're a failure for being depressed, because there's a lot of shame around having psychiatric issues. Although I think the younger generation is having less shame about that, and more open to psychotherapy and treatment. So when somebody's treating somebody with psychotherapy, if they meet that cluster of symptoms and they're not improving with psychotherapy, they really need medications. And the two of them are not contradictory, because getting rid of symptoms doesn't mean the issues are gone of whatever is going on with them. So we now know, I mean, if we look at the history of psychology, many years ago, back in ancient times, someone would have a lot of problems. They'd be writing a story about him, and they'd say, no wonder he's so messed up as a grown-up. He was a bastard. He never had a chance to have a normal life. Well, what they're really saying there was that our childhood experiences affect us as a grown-up. But that wasn't actually proved until Freud. Freud, he was a little hung up on sex, I'll take that, but he also was a real integral figure in the evolution of psychiatry and psychotherapy. Because he was the first one to show that an unconscious issue could affect my conscious behavior. We already knew that way back in literature, but no one had ever showed that. He did it with someone had a slip of a tongue, and that actually had meaning for him, and it was outside of his conscious awareness. So that really opened the door to validating how much our family of origin growing up issues could impact the brain. So if I say to you, when do you think you learned the word baby or mom or cake or birthday? By 3 or 4, somewhere in there. So while you're learning language, you also learn your identity. And that is your temperament, your genetic makeup, and then how you bond day in and day out with mother and dad and sibs and peers. And those experiences we have, they're reciprocal. So I stub my toe or I fall, and mom either nurtures me or she doesn't. Or I make a mistake and dad either yells at me or corrects me in a more caring way. And as that happens over and over again, I draw conclusions, sometimes conscious, like, oh, I'll never do that again. But a lot of times unconscious, like, oh, it's not okay to trust. Or when there's dysfunction in the family and a lot of yelling going on and anger, the child absorbs it as it's about themselves. So they end up feeling a deep sense of, I'm not worthwhile, something's wrong with me, but they don't know how to make sense out of that. And of course, it's painful. So we wall that off. And we develop ways of coping. So we might become a rebel and get into smoking marijuana in high school, or we might become an athlete and a scholar and try to be a good person. And that can become a problem in itself. If somebody tries to be too good, they're trying to wall off the painful part of themselves. And if that's too much of a walling off, it costs psychological energy, and it becomes a problem in terms of relationships. And self-identity. So psychotherapy is a process of learning about what makes me tick, what am I holding inside of me, how is it coming out, how's it manifesting? And so Freud opened the door to that. And then Anna Freud, his daughter, looked at defense mechanisms in terms of how does brain deal with feeling inadequate or feeling affronted or feeling like I must accomplish something. And of course, that's affected by whether I'm hyperactive or obsessive or laid back, my temperament makeup, right? So I think they're both really important. Everybody I treat with medications, I recommend they get in therapy. Not all people do. Some people are not motivated to do it. And I caution them that the issues that they're dealing with are not going to go away with the pills, because as I said, pills don't teach skills.
Mm-hmm.
But pills are very important because and the average incidence of mental health issues is kind of interesting. So if we look at the population of America, there were two major studies done about this, national study. So the incidence of major depression is about 7 to 8% of the general population. That's a diagnosable mental illness. Anxiety, generalized anxiety disorders, about 10%. Addictions of all sorts are about 10%. So next time you go into church or in a crowd to a football game, look ahead there. 1 out of 10 is going to have either both the anxiety and addiction, or some will have untreated or treated major depression. Most people with major depression, only about half of them get treated, and most of them are treated by family doctors. Only about a small percent, 20% or so, or maybe 25% are treated by psychiatrists. So I was talking to a doc last week. He came across a statistic that was startling, that the normal 8% incidence of major depression, he read an article that said it's now 30% of the general population with major depression. That's really high.
Yes.
I mean, 1 in 3 people has a diagnosable, not just a bad blue day, but actually a change in their functioning that is a biological change. So I think they're both extremely important. I think people doing therapy, if somebody has all those symptoms and they're not getting better with the therapy, they really need to get medication.
Yeah.
Or if they're suicidal, then I would not wait. I think they need medication.
Sure. Absolutely.
And you don't find out about being suicidal unless you ask, because a lot of people won't tell you.
Yes.
They're not going to say, oh, let me sign up, I'm suicidal. They won't do that. I think there's more cooperation between psychiatrists and therapists. I think they both see what a valuable skill they bring to the table of helping people.
Yeah. And so for some people who you've seen who haven't really been improving in psychotherapy, their depression isn't getting better, and then they get on psychiatric medication, that you generally suggest to continue in psychotherapy. And do you often see shifts when both are used in conjunction that you might not have seen if they hadn't gone on meds?
Absolutely. I do see shifts, and they're important. And I do encourage them, even though their symptoms are less, that they still need the therapy part. As I said several times, pills don't teach skills. They keep sabotaging a relationship, for example, or a bright person who's not succeeding in work or in school, but has underlying conflicts about anger about authority or not permission to be successful, some issue inside of themselves where they self-sabotage. Mm-hmm. And so the psychotherapy is crucial for that.
Absolutely. And you mentioned earlier COVID, and I'd be curious to hear about what sort of impact you see COVID having with depression and anxiety, for example. I mean, you mentioned that statistic recently, 30% of the population now contending with, you were saying that was major depressive disorder.
That's what the doctor said. I haven't seen that data myself, so I'm relaying something that I heard, but it's certainly significantly higher.
Sure.
So particularly looking at children and adolescents, the uncertainty, the social isolation, and the family angst can cause children to worry a lot about what's going to happen with school, what's going to happen with their friends, what's going to happen. They absorb their parents' fear and uncertainty and anger and confusion, and now the child is carrying that. So one of the original studies about this was interestingly enough done in China. They looked at children and adolescents 7 years to 18 years of age, and there were about 360 children and about 3,200 adolescents. And they included depression, anxiety, and coping scales. There was 22.3% clinical depression, discovered, where the norm of that would be about 13%.
Hmm.
So that's a significant jump in
Yeah.
on the depression scale. And then another study in America looking at sort of a meta-analysis of 63 studies of 51,500 adolescents, that the social isolation and the loneliness increase the risk of depression up to 9 years later when we
Hmm.
look at children and adolescents who are exposed, and that right now it's much higher than usual.
Yeah.
So the suicide rate for adolescents 14 to 17 has tripled.
Hmm.
With COVID, we've seen a massive increase in reporting of child sexual abuse and physical abuse at the CPS kind of entities throughout the states. Divorce is up, and of course, alcoholism and drug abuse are elevated as well. So family violence is more there. And if you have a dysfunctional family, it's going to be more dysfunctional. If there's a functional family, it can actually grow. People can grow better together. But if it's not functional, the addictions and that social isolation is a cauldron of explosive, painful behavior for children and
Yeah.
adolescents.
So for parents right now who are observing their children, being isolated from their peers, and maybe struggling in ways that they hadn't, with lack of motivation, depression, more anxiety, maybe. What are some recommendations you might make? What are some things that you'd like that parent or family member to know?
Yeah. I'd like them to do with their children what they need to do with themselves. And that is to try to stay optimistic, not get caught up in pessimism, because that's so easy to do when we're isolated and lonely. Um, it is crucial that we actually write down a structure for our day, because if we don't structure our
Yeah.
day, it just ebbs away into nothingness.
Yeah.
And good parenting involves helping kids structure their times. So sitting down with the child and coming up with a structure about when they're going to do their schoolwork, if it's online, and how they're going to spend more time doing their homework, and then how they're going to play and that kind of things. So structuring time is crucial, trying to stay positive, because negativity easily grows. As we see, the death rate is quite amazing. And so the national death rate is astronomical. Arizona has recently been, in the post-Christmas time, we've had the highest rate of COVID of any place in the world.
Yeah.
So that's pretty remarkable.
Wow.
So, so structuring time, staying positive, I think, and hopeful is important.
Hmm.
Therapy when available, and they can help orchestrate online meetings with other kids. And some kids, their parents let them play together. So, I mean, so anything they can do to help structure the time for the child and keep them busy, just like we need to stay busy.
Yeah. Yeah,
So,
I love that piece, that structure. It can be so easy because before COVID, right? A lot of us had 9 to 5 jobs. Or we had,
right,
or I was, a student. I still am a student, but my schedule is a lot more structured, going into class in
sure.
person, going to internship in person, and so I've definitely found that for myself. And yeah, someone I was talking to recently was talking about how they've had a shift and created that structure in their life, and it's been paradoxically a very freeing experience, and allowed for them to express themselves creatively. And so,
Right, right.
yeah, I'm really drawn to that. That seems important in this time.
It's so important, because loneliness and sitting around doing nothing is a recipe for getting depressed and being more dysfunctional and turning more to substance abuse
Mm.
to calm the anxiety that comes up from being just sitting there and feeling terrible.
Yeah, yeah, absolutely. And So you treat depression with psychotherapy. You treat depression from a psychiatric lens, and you also have this modality that I don't know much about. I'm interested to learn. Is TMS? Is that right?
Yes. So back in the 60s and 70s, we had the tricyclic antidepressants. And then at the end of the 90s, the beginning of late 80s, about 1990, the serotonin reuptake inhibitor medications like Prozac was the first one that came out in 89, I believe, followed by Zoloft, Paxil, and now Lexapro and a number of medications. And then some of the serotonin agents that also affect norepinephrine, like venlafaxine and Cymbalta. And those are brand names, of course. There's a significant chunk. So in 2005, this major study was done looking at treating depression. It's called the STAR-D study. And that study had 5,000 patients. And they were in 25 different locations, mostly in Texas, but throughout the country. And they were regular family practice and psychiatry offices. So this is most of the studies with drugs are like a really pristine group of people. These are real people with divorce, addictions, various other things going on. So they studied them for a year. And for the first 3 months, they gave them one antidepressant called citalopram. And if that worked, great, they went on. If it didn't, then they went through choices of adding Wellbutrin, psychotherapy, and 3 other choices up to the course of a year. So the take-home message from that is at the end of the year, through all these different phases of carefully monitored treatment, about 2/3 of the people got reasonably better. Which means, of course, a third didn't.
Uh-huh.
Well, that third are what we call treatment-resistant major depression. And we try all sorts of different things to treat them because it can be a very debilitating illness. It causes great disability, difficulty in the family because they're irritable or they're shut down, and difficulty with functioning on a job. I think depression is the costliest illness in terms of job dysfunction. And so anyway, that third that isn't treated, we have now, some of them get treated with electroconvulsive therapy. We really reserve that for somebody who's really suicidal and has been through many treatments and is at great risk. And that's the gold standard because that's in the 94, 95%, 90% successful. That does bring with it problems. There are memory problems, but that's much less now since we're doing it more briefly. And recently we had ketamine, the new kid on the block.
Mm-hmm.
And ketamine is an anesthetic agent that it used to be used with people, but they stopped it because it causes dissociation. And that's an amazing phenomenon. If somebody's acutely suicidal and medications aren't working, ketamine can get them better in hours. However, that's about a 40 or 50% response rate. And in 2 weeks, they're sick again. So they got to keep doing it, and it can peter out over time. But it's a remarkable intervention, briefly. What ketamine has done mostly has led us to a whole new biological avenue of investigation for antidepressants, because it looks at GABA, one of the major neurotransmitters that we haven't really explored what to do with in terms of depression. And there's called the NMDA receptor, and that whole area is going to give us a whole bunch of new antidepressants in the next 5 years. The old ones, the ones that they're not old, but the previous serotonin, dopamine, and norepinephrine were the neurotransmitters that we've been looking at with the current antidepressant medications. So ketamine has a role, but it's limited. And another thing that came up is back in 1980, this fellow in England was mapping out the motor and sensory cortex using a magnetic stimulation to the brain. And some of his research students said, hey, doc, since you've been doing that, I was bummed out pretty bad, but now I feel better. So the light went on in his head saying, maybe this could be an approach for treating depression. So that got a lot of people excited. that a magnetic wave applied to the brain could help treat depression. So in the 90s, there were many people trying this, and they didn't quite know where to go, how much to give it, how to get back there. But by the late 90s, PET scans and people with seizures, they were able to find that, and people post-stroke, not seizures, but post-stroke, they're able to define that the dorsolateral prefrontal cortex is low in metabolism in major depression. And the midbrain structures, the hippocampus and the midbrain, are higher in metabolism. They're more on fire. And when people get better, the D.F.A.P.A raises this metabolism to normal, and the midbrain fire calms down to normal. So 2005, Neurostar developed a machine that would take a magnet, a metal magnet, piece of metal that's in either a circle or figure eight, and place that over the brain, and they would send alternating electrical stimulation to that. And that magnet would then send off an electromagnetic wave that would go about 3 centimeters unimpeded through the skull into the brain and trigger the neurons to fire in the brain. And so in the original studies around 2005, they got approval in 2009. This process, they did a sham, and it's a tapping sensation on the scalp. So they had to have a sham that sounded like that, that felt like that, but wasn't actually doing it. So they did the treatment for about 37 minutes a day, 5 days a week for a month. And they had about a 60% response rate, meaning they got better, 50% better on the Hamilton depression scale, and about a 30% remission rate where they felt fully better. And these were people that had been through 3 or 4 antidepressants, almost all of them had psychotherapy, and they were still very ill. So that got FDA approval in 2009, 11 years ago. So now our response rates are better for a couple of reasons. One is we go for 6 weeks instead of 4. And secondly, we leave them on the medications they were previously on, even though they may not have been doing a full job. Having something there seems to make a difference. So now our response rate is about 70%, and the remission rate is about 40%. It still leaves that 30% that doesn't get better, and that's disheartening, of course. After about a year, about a third of people need retreatment with 3, 5, 7 sessions. In the original studies, they did 15 sessions, but I don't think we actually need that many. Sometimes people have been doing one preventative treatment a month to keep people from going back into the depression. So this is a subset of people that have a severe depressive disorder. Not uncommonly, they've had trauma in their life as well. Anyway, so that's really a very exciting thing. And I've been doing that in my office for years now. And so one of the challenges, of course, is finding the right spot. So if we can do fMRI guided to find the exact right spot to treat, because it'll be low in metabolism, that's the most effective, but that's way too expensive right now. So we're looking at different ways to approach that. There's another machine called Brainsway, which is more like a helmet, and that's better at being able to find the correct spot to treat. And it also is FDA approved for OCD, as well as major depression. And they're working on smoking studies as well. And that requires treating in different parts of the brain that we can't get to so easily with the Neurostar device. And I'm getting one of those devices this year, so I'm very excited about that. So anyway, it's been a very interesting, valuable tool in our toolbox to treat more severe cases of depression that can be extremely disabling.
Absolutely. Well, I'm really happy that this has come onto my radar as a new clinician to when there's someone facing treatment-resistant depression. This seems like a great resource. And I was wondering, as you're talking, are there any side effects for TMS?
In the original studies, the dropout rate was 4% for headache from the tapping sensation on the scalp. I've only had one person drop out in 10 years from that tapping sensation because I start really low and go slowly. So in the first 10,000 treatments to get FDA approval, that was the major side effect. Sometimes there's the the facial nerve or the trigeminal nerve can have muscle spasms and kind of shooting pain, but pretty rarely.
Sure.
In the next, that was 10,000 treatments to get the FDA approval. Between 10,000 and 100,000, they had 3 seizures. One was drug abuse, one was probably treatment error, and the third one was changing medications in midstream. So now we don't change medications once they start. Whatever they're on, we leave them on that until the treatment's over. So between that 100,000 with NeuroStar device, and now they're at about almost 4 million treatments. They've had a handful more of seizures, but not a lot. When we talk to people about that risk factor, we talk now about being 1 in 32,000 treatments, because we can't just use the NeuroStar device. We have to talk about what's happening with all the other devices.
Sure.
So it's a very small risk, but it's real. We can't treat somebody who has a pacemaker or any kind of metal object in their head or neck. So if they've had neck surgery or dental implants are okay. That's the biggest risk factor, and we watch for it very carefully.
Mm-hmm. Yeah.
And it's not often, obviously.
Sure. And Dr. Schulte, you have a lecture online that you wanted to talk a little bit about. Will you tell our listeners a bit about that?
Sure. So, and your granddad came to the lecture, actually.
Oh, really?
Yeah, he liked it. He
Nice.
said,
Oh,
he
good.
was very happy with it. He encouraged me to go on with it. So it's a long lecture. It's about 3 hours long. And it's on a video on my website. So the lecture is, we talked a little bit about it today. I go back and look at how do we get our sense of self-identity, given our temperament, and this interaction day in and day out with family and peers, and the conclusions the mind reaches. So I look at that process, and then how the brain holds it and where it holds it, and then how it comes out in our adult life. And there's some interesting studies there about genetic factors and the mediation of what happens with anxiety in the mind-body interaction. And then looking at options about how to change it. So in 1980, Aaron Beck, a psychoanalyst in Philadelphia, wanted something more practical for his patients. And what he observed was, if we have depression or anxiety, the mind automatically shoots off negative thoughts. Oh, I'll never get better. That doesn't work out for me. And look at just constant negativity. And if we let that go by, of course, it reinforces the depression, the anxiety. So what he observed was, if we see that thought and identify it, and then question how accurate it is, and get our mind out of there over and over again, we can actually use our observing mind, observing ego, to see those thoughts, move out of them, and help decrease the depression and anxiety significantly. And I think that's a valuable tool for everybody to learn, because we all can get caught up in negative thinking sometimes, for sure. So anyway, that was the beginning of cognitive behavior therapy. And that is a very important fundamental. I think all therapists are trained in that, or should be. And, that's insurance really wants us to do that, because it's a very useful tool for depression and anxiety as part of the therapy. It's not the whole story, of course, but it does give each of us the ability to monitor those negative thoughts and step out of them over and over again. And just doing that helps change the biology of the brain. So that was a very valuable addition. So anyway, that talk that I gave is, I've got great feedback about it. Sometimes maybe a little bit too technical, but it is very helpful. And it's a good overview of human development. And also it's an overview of the psychotherapy process, how we learn what we learn and how we can change that today.
Absolutely. Yeah. And we're getting to the end of our time here, Dr. Schulte, and the question I like to ask at the end of the interview is what's a message of hope that you'd like to leave the listeners with?
I think the idea that we can change what's bothering us is a fundamental concept, because some people think, I've got this, I'm screwed, there's no way I can get out of it.
Yeah.
And that's been their life experience. So they're not making it up. They've been stuck there. So the idea that there are ways that we can use our mind to combat depression, anxiety, and things that we're repeating over and over again that are dysfunctional. There's been a great explosion, I should mention also, in addictions in terms of looking at the dynamics of that and ways to treat it, both substance abuse and behavioral addictions like sexual addiction. In fact, your grandpa wrote a couple of books about that, as well as did Pat Carnes and others, to introduce us to that unknown addiction that's been sort of not given enough credence, because I think it is very, very significant phenomenon. And addiction involves, just a side about that, two things. One, people like to get high, but two, it serves a purpose. And the purpose frequently is to wall off those painful parts of ourselves that we don't want to deal with. That could be depression, anxiety, childhood trauma, upsets that we don't know what to do with. And so I'll just have that extra drink or this extra behavior, and I'll get rid of that, of course. And then now you've got two problems. You got the addiction problem, the underlying problem is still there. So I think the idea that we can do something about what's going on with us emotionally and mentally, and it's not just a given that we're stuck with.
Oh, that's a nice message to leave with. And if our listeners want to get in touch with you, should we direct them to your website, or where would be a good place for them to get in touch?
Well, the website will tell them about, they can purchase the video there.
Okay.
And it tells them a little bit about my background. And then my office on Indian School and Scottsdale Road in Scottsdale, they could call there if they are interested in making an appointment.
Perfect.
Should I give you that phone number, or you're going to give it?
Yeah, go ahead. Yeah.
480-941-9004.
Perfect. And I'll put that in your website link in the show notes as well for the listeners.
Right.
So
thanks so much.
Yeah.
I appreciate you having me talk with you today, Andrew.
Well, thanks. Thanks for the time. I enjoyed the talk. Please press the subscribe button, as well as rating and reviewing our podcast. This helps others connect with what you've been hearing. If you have any questions, please contact us at themindofatherapist@gmail.com. These questions will be kept anonymous. I want to thank Eric Price for the wonderful music you hear in this podcast. Additionally, this podcast was created to provide accurate and authoritative information on the subject matter. Although we are interviewing licensed therapists, they are not your therapists. This podcast is not intended to serve as direct medical advice and should not be used as a substitute for direct professional help. It is given with understanding that neither the host, publisher, guests, or PCS are rendering legal, clinical, or other professional information. If you need a professional, we encourage you to find one. Visit Psychology Today to connect with a licensed clinician near you.